Thank you. I'm Charles Khoury. I'm from the University of Alabama at Birmingham School of Medicine. I'm an emergency physician there. And I also, in my spare time, I guess, I do wound care and hyperbaric medicine. And I thought this topic was pretty interesting because I see a lot of chronic wounds in the emergency department, as most of you do. And the question usually is what to do with these wounds from an emergency medicine point of view. So I want to briefly talk a little bit about actual healing of wounds. So an acute wound, you have about an immediate response, which is hemostasis. Then you have this kind of slow progression of inflammation to granulation to remodeling. And that remodeling can last up to 2 years with scar tissue formation and things like that. This is not what I'm talking about in the emergency department. Those are easy. We're really good at acute wounds. Now the chronic ones is where that acute wound does not go through those steps and you develop this wound that just won't seem to heal. And that's where those patients are typically referred to me in clinic. But I think that we as a whole in emergency medicine do kind of a poor job of taking care of them on the front end. So I want to talk about 5 types. I really want to talk about 4 types. I split them up into 5 because I got this little junk drawer of like other. But pressure ulcers, diabetic ulcers, arterial ulcers, venous ulcers, those are the things that we really need to be aware of in the emergency department. I want to start with pressure ulcers. These are the ones that are usually over a bony prominence like the sacrum, the hip, the heel. They develop this kind of crater-like appearance. The thing about these is they're often painless. We have to roll patients to find them sometimes, especially chronically debilitated patients. So the only way these are going to heal is to relieve pressure. So naturally, the most important emergency physician action would be to actually relieve that pressure. So in the emergency department, if you see one of these wounds, the thing that you can do for this patient is find a way to offload them, whether that's encouraging the family to put like a foam block under the leg or roll them more often. But that's the critical action in the emergency department before you refer them to a wound care center or to their primary doctor. Diabetic ulcers are a little more complicated than that, a lot of times because there's more than one thing involved. They always have an aspect of venous insufficiency in them, but they're also associated with neuropathy, microvascular disease, macrovascular disease. Now, the treatment in the wound care clinic is debridement, and a lot of times we also do the pressure reduction, and we do things like orthotic shoes and total contact casts. I recognize we can't do that in the emergency department, but what we can do, the most important thing you can do for these patients is glucose control and treating infection if it's there. The majority of these patients have really high glucose levels. They have high hemoglobin A1Cs. A lot of them come to clinic with hemoglobin A1Cs of 16 or greater. So it's really important that we start that on the front end of encouraging them to actually work on their glucose control. Arterial ulcers, I think this is the one that emergency physicians are most frightened of. And this is kind of the premature calls to vascular surgery very quickly because you see these punched out lesions on the feet. Now, the thing about arterial ulcers is they take a while to form. This is not gangrene, these are ulcers. So it's not as emergent as we think it is. They tend to occur distally. You often feel diminished or absent pulses. They have this punched out appearance. And then the treatment is vascular surgery. It's usually revascularization, or if that doesn't work, then it's amputation. But the most important thing we can do in the emergency department for arterial insufficiency ulcers is to recognize the arterial compromise. And this is one of those things, again, that we've all learned how to do, but we don't always do in the emergency department. So you'd be surprised how many residents look at me like with this confused look on their face when I ask them about the ABI, or the ankle brachial index of the patient. I'm not going to go into how to do it, and I'm not going to go into like all the specifics of it, but what you need to, this number that we need to have in our heads is 0.4. If it's less than 0.4, then it's unlikely to heal, and that's going to require referral to vascular surgery. Does that require emergent referral? Probably not, but usually with an ABI of less than 0.4, I start doing a workup myself, like even ordering vascular ultrasounds in the ER or possibly consulting vascular surgery if I can't get them follow-up in the next few days with vascular. Finally, there's venous ulcers, and I said arterial are like the scariest ones for the emergency physician. These are the ones that we are the worst at, in my opinion, is venous ulcers. We have a lot of misconceptions, and the reason is because whenever we see a venous ulcer, we love to treat cellulitis, and oftentimes that's pretty unnecessary. So there's some pretty cool studies which I'm going to talk about in a second here, but I want to review the actual ulcer a little more. Oftentimes these are very painful because you still have arterial flow to that area, but you have compromised venous return to the heart. There's a lot of edema present. There's the possibility that you could also have some concomitant arterial disease. So one thing you can do for these is feel for pulses. If they have a good DP and a PT pulse, it probably is just venous. An ABI greater than 0.8, it probably is just venous. But the most important thing we can do for these in the emergency department is to reduce swelling. And we do that by things like elevating the leg, getting them to elevate the leg above the level of their heart at home. And I usually tell patients like 16 to 20 hours of their day should be elevating that leg. Compression is something we do in the wound care clinic, but I don't expect people to be able to do Una boots in the emergency department. That's actually not really good care if you don't have someone to follow up with. But I do think we can use things like ACE wraps and Curlex wraps. And I write prescriptions for sleeve compression stockings. It's pretty simple. I usually write 20 to 30 millimeters of mercury or 25 to 35 millimeters of mercury, and I just write for compression socks, wear daily, dispense number 1 or 2 or 3, and I just give them refills because it's very simple, because even our nurses should be wearing these. If you're up on your feet 12 hours of the day, it really does help to be wearing some compression stockings. So that's not a high-risk medication to prescribe at all. So there's a really good study in JAMA Dermatology last year, and it looked at patients being admitted to the hospital with the diagnosis of lower extremity cellulitis. And what they found was 30% of these were not actually cellulitis. They were misdiagnosed. And they extrapolated the numbers, and they're thinking maybe $200 to $500 million nationally is being spent in avoidable expenses. So we do overcall cellulitis. The other thing is, other studies have showed bilateral cellulitis is only present in 2% of cases. So if it's both legs, it's almost always venous stasis. A simple way to document, just describe what you see. Where is it? How big is it? What color is it? Erythematous. And once you write all those out, you're going to have a really good description. Finally, when it comes to cleaning and dressing the wound, in the emergency department, I suggest soap and water or normal saline. It's very simple. And I have no ties to these, but I typically use Meta honey, which is kind of medical honey. And what that does is it helps debride the area if it's necrotic. And if it's not necrotic, I use something like Mepilex, which we use in burns a lot. And what that does is it wicks away some of that moisture and allows good healing. So find a couple of products that work with you and use them. So kind of a simple scenario is if it's wet, you want to dry it. If it's dry, you want to moisten it. If it's irritated, you want to soothe it. If it's chronic, you want to irritate it. That's what we do in clinic. We debride them. And if it's palliative, comfort it. I tell every patient, you need to elevate. You need to reduce swelling as much as you can. Offloading is essential. You can't keep walking on the wound. Glucose control is important. Smoking cessation is incredibly important. Most patients don't know that it's regarding wounds. That it's very important to get follow-up, and I give them return precautions. And that's what I've got.